Peripheral vascular disease or peripheral artery occlusive disease or peripheral artery disease is where you get narrowing of the blood supply to the lower legs, usually, very occasionally the arms, but by and large the lower legs. And it's broadly split into 3 symptoms. When you walk, when you're sitting down, your heart pumps out about 5 liters of blood a minute, and of that, about 500 mils goes to your, or a pint in all imperial goes to your legs. And because they're just sitting there not doing anything, they don't even need that much. They can get by on a lot less than that. However, as soon as you start walking, your legs need a lot more blood. And that's why your heart rate goes up and you pump more out. And if you're walking briskly, then you're probably pumping out about 10 liters a minute. And of that 10 liters, the majority of that extra 5 liters that you're pumping out is going to your legs. So 2.5 to 3 liters a minute going to each leg. And your leg uses this in its muscles to power the muscles. And it's like fuel in a car. Because we are designed to be able to run really fast when we're young, and when we're chasing buses and so on, we are engineered such that we can actually pump up to 20 liters in your 20s out of your heart a minute, and pump almost 8 to 10 liters into each leg. You can really, the blood supply, the sort of size of the blood vessels that go to your legs is really quite big. And they're like storm drains designed for these emergency bits when you have to run away from a woolly mammoth or whatever. However, the vast majority of the time, we never use that. And the older we get, the less we use it. And in fact, you can sort of slowly, just as your amount that you walk decreases with time, you could actually narrow your arteries quite significantly, and you wouldn't notice because you never run for a bus, partly because you don't want to, partly because your joints won't let you. So as we age, we need our arteries to be smaller in size because we're not all running marathons in our 80s anymore. So that's the basics of it. You've got a blood supply, big vessel that's taking blood to your muscle. That artery can age and narrow up and fur up, for want of a better term, and that process starts when we're about 15 to 18 in everybody. That's just the way it is. And as we get older, depending on genetic factors and environmental factors, the biggest of which is diabetes and smoking, we can speed up that process or we can slow it down. So if you have a fit individual of the age of 60 who's never smoked and is not diabetic and has kept and has good exercise, then the chances of having significant peripheral vascular disease at the age of 60 is extremely small. Whilst if they're a smoker and have been diabetic for more than 10 years, then their chance is probably about 50 times higher of having hardened the arteries to the legs significantly. What symptoms you get depends on what you do with your legs. So if you don't walk very much, you might never notice. You can narrow your blood vessels by over half, and you might not be able to run, but you'll still be able to walk. Peripheral artery disease is the first symptom of peripheral artery disease is when the needs are, when you want to walk further than your blood supply will let you. So this may be that you, if you're a fit runner or a keen runner or do a lot of walking, this is when you'll begin to, this is probably, you'll notice it earlier than if you're somebody who's got arthritis or somebody who doesn't do very much exercise. So the amount of disease is dependent, when you present, depends on your activity. So the big symptom is what we call claudication, and that's a cramp-like sensation in the muscle when it's saying that it's not getting enough oxygen from the bloodstream. And it's typically feels like a tightening in the calf. It's the most commonplace because the calf's the biggest muscle when you're walking. It does most of the effort when you're walking, and it tightens up after you've been walking for a while. Usually a good average is, say, 200 to 400 yards. You're fine setting off, and then a little bit, it just begins to tighten a bit. And then as you continue to walk, the calf slowly runs out of muscle, tightens and tightens, and then it seizes up, and you physically can't walk anymore as it's run out of oxygen. You wait for a few minutes, the oxygen replenishes itself as the needs of the muscle have gone down, and then you can walk again. And you could sort of walk a further, say 100 yards, 200 yards, and then the same thing will happen again. You'll stop, and so the cycle repeats. And it's relatively predictable. Most patients with claudication will know how far they can walk before it starts, and it will vary a little bit from day to day. And it'll also vary on hills, worse going up hills, worse if you're carrying stuff, worse if you happen to be anemic for some reason, worse if you've got a chest infection and aren't getting as much oxygen into your blood and so forth. That is the main symptom of peripheral artery disease. It's a bit like angina. Angina is the heart muscle getting pain because it's not getting enough oxygen because the arteries to the heart are clogged up. It's exactly the same thing, but in the legs. The biggest difference is that the heart isn't allowed to stop. So the heart can't take a rest. Therefore, you have to, when you get angina, you absolutely have to stop exercising, slow down, reduce what the demands on your heart, and to let it recover. Whilst with your legs, you can push it until you physically can't walk any farther. And actually that will help the body to push more blood into the muscles. And then they can recover over the next couple of hours when they're not having to do anything, and the cycle can repeat. And that's the main reason, that's the main sort of symptom of peripheral artery disease, and that's called claudication. So the most common treatment of peripheral vascular disease initially is just walking. If you asked me to run 5 kilometers, I suppose I could do it. If you asked me to run a marathon, I don't think I could today. But if you incentivized me enough, I'm sure I could do it next year. And it's a matter of running till it hurts, and then running a little bit further, and then taking a couple of days off, and then the next day doing the same thing until eventually you build up and you build up. And your muscle, my blood supply doesn't change. What happens is my muscles get used to doing more with less. They adapt. And the same thing happens in people with peripheral vascular disease, but at a lower level. If they can only walk 200 yards, it's frequently you find that patients have had a period where they've been inactive. They've been ill for another reason, or maybe the lockdown has stopped them walking, and their sort of general fitness has dropped. And then they set off walking and suddenly find they can't walk as far as they used to, and they think, gosh, what's going on? In fact, what they're doing is they're revealing the underlying peripheral artery disease that they've had for years, but just never noticed because they've been fit enough to walk through it. And if they can get them push it a bit and get themselves back to their previous level, then actually all they need to do is to walk on a regular basis as far as they can and a little bit further. And that's the single best thing for managing peripheral vascular disease. And then obviously you want to try and stop making it worse. So you look at the risk factors, so which is blood pressure control, managing cholesterol, managing diabetes, and of course trying to stop smoking if that's an issue. As in the heart, where you can do balloon angioplasties and stents and bypasses, you can do exactly the same in the leg arteries, depending on symptoms and depending on the ability to respond to exercise, and of course, what the ambitions of the patient is and the general fitness of the patient is. It also depends a little bit on the size of the arteries and how, which part of the leg the arteries are affected in. But yes, angioplasty, which is where you put a wire in, blow a wire across the narrowing of an artery and blow a balloon up to stretch that artery, and then possibly leave a stent behind, which is a metal cage that you leave in the artery afterwards to stop it collapsing back down again once you've stretched it up, which you don't always have to do, but you can do. That's a sort of fairly standard treatment for peripheral artery disease, depending on the level of symptom and the level of need of the patient. Some patients, if you've got a 55-year-old postman who needs to keep his job, then treating and he's walking 200 yards, but he can't do his job, then quite clearly you'd want to do something to help him. Whilst if you had somebody in their 80s who was able to walk 100 yards, but actually didn't really need to walk any more than that, then on a regular basis, because their arthritis in their knees and hips limited them, then you wouldn't necessarily need to. So it's a balance. But the treating with angioplasties and stents is relatively common. It's not a cure, depending a little bit. The smaller the artery you treat, the shorter period of time these angioplasties and or stents tend to last. But you can, in larger arteries, you can get good results with stents lasting 10 years or more. And with smaller arteries, perhaps a couple of years. It varies a little bit. It's no replacement for exercise, but it is a good augment in the correct patients who have the simple claudication style pain and not the more severe end of the disease. And then, of course, if it's a long block, usually in a leg artery or perhaps in the artery slightly higher up that feeds the leg from inside the abdomen, then you can do bypasses, which is actually a surgical operation. You have to make a cut, find the artery, and then put a bypass conduit, either a patient's own vein, a spare vein they may have, or a piece of plastic tubing to take blood around the blocked artery to an area that's open beyond the blockage. They tend to last longer than angioplasties and stents, but obviously it's a bigger commitment for the patient to go through a bypass than it is to have an angioplasty. So you have to, again, it's about having a good relationship with the patient and trying to understand what their needs are and what their expectations are, and for them to know what risks they're taking. Gosh, well, the bypasses, there's advances being made all the time. There's from an angioplasty and stenting point of view, probably the most interesting thing recently is shockwave treatment, which is a way of, if you've got a very, very hard calcified narrowing where the body has actually tried to turn the narrowing into bone, that doesn't respond very well to a balloon, but there's now a shockwave treatment where you can put in a little ultrasound shockwave wire that will help to break that calcium and hardened artery up before the balloon and give you better results. We're having some interesting results with shockwave treatments in some segments, where previously we would have thought the only way to do it was with surgery. And from a surgical point of view, probably the most interesting advances is that we've got, over the last couple of years, we've found a new type of conduit, a new type of bypass material. So previously, we've either had to use the patient's own vein, which would be a non-varicose. You can't use a varicose vein, but you can use a non-varicose great venous vein that's a spare vein in the leg, that you can take it out and turn it around, or take the valves out and use that as a bypass conduit. And that's really very good. But if patients either have a vein that's too small or too large, or has been taken out for disease processes, and they don't actually have a vein to use, then you have to use, previously have to use a prosthetic like PTFE or Dacron, which are man-made materials. More recently, we've now got what we'd call bovine material, or sort of, which is it's a biological bypass, which is not but artificially created. And these seem to give some of the advantages of the PTFE, which is it's just on the shelf and you don't have to take it out of make cuts to take it out of the patient first, but also has the advantages of the vein and that it resists infection. So that's probably the most recent advance in bypasses that we've been taking on over the last year. PVD, you can get rid of if there is an isolated area, so you just have hardened one artery that's hardened, and you core that artery out surgically and take away the hardened area and throw it in a bin and sew the artery up again, then you're effectively resetting the patient back to where they were before. However, that is phenomenally rare. The vast majority of patients, they're getting narrowings in their arteries all over the place, and what you're trying to do is just treat the worst areas and manage the patient, because we're all getting older, and if somebody works out how to stop it, can you tell me? That would be nice. We're all getting older, and what we're trying to do is to stay as active as we can for as long as we can, whilst not upsetting the apple cart and not taking too many risks. And it's a careful balance that you have to think about. So I think curing peripheral vascular disease is impossible any more than we can stop ourselves getting older. It's about trying to manage the condition.